Good morning to all of you. Thank you so much, and thank you, respected sir, for this wonderful opportunity. I'm going to make you have a shallow dive, not a deep dive, into the ocean of hypertension. And let me tell you, this is going to be a very revealing and a heart-to-heart talk. You will really understand the nuances, the things that you, not only as a gastroenterologist, as a hepatologist, or you should know that what and how we should be managing hypertension. So let me start, and I'm going to give you 7 cases and 7 different ways how you will be able to understand and what exactly you should, as a gastroenterologist, as a hepatologist, and as even a surgeon, and as a person who's taking care of the self, should know. You would be surprised that almost 33% of the cases of hypertension are in urban population, but overall prevalence in India is almost 25 to 30%. But unfortunately, 20% remain undetected, 30% are partially treated, and almost 20% are not at all aware that they are having hypertension. That's the problem. So that is where we are standing. So it would not be surprising that if a person walks in and you are just checking your blood pressure in a year or so and the pressure is high. This is always a possibility. So we should be very much aware of every single patient. Even if he says that I'm not in hypertensive, take a time to measure the blood pressure rightly. So if we have a 38-year-old male who comes with a routine checkup in your institute, and once you measure his blood pressure, it's almost 155 by 95. I would be very much happy to treat the patient immediately. Oh, let me write a medicine for hypertension. Do we really need to do that immediately with a single reading? The answer is no. The answer is no. Even if the reading is very high, we need to do the reading in the right way, with the proper instruments, and with the way it should be properly done. And what would I would do? I would definitely like to take the BP again of the patient. Again, I would like to take the blood pressure, and if the repeat BP is 148 by 92, do I still suspect hypertension? No. The answer is still no. I would like to arrange for either 3 office readings, or I would like to go for something that is known as ambulatory blood pressure monitor. So my first message is, we are now evolved human beings. The simple instrument measure of hypertension is no more a diagnostic way of treating hypertension or diagnosing hypertension. As an institute, it is our responsibility that we must have a simple ambulatory blood pressure monitor, even for our patients, for our simple outdoor patients, and also for our own selves. Ambulatory blood pressure monitor is going to really bring out certain cases which will be mind boggling, which probably you may not be even aware of. So if you say I don't have an ambulatory blood pressure monitor, have 3 readings at least. Ask the person to sit down. Remember how the blood pressure has to be taken. Patient has to be sitting down. Legs should not be folded. That is very important. No coffee, no smoking. A room which is quiet, and legs should not be folded. Back should be supported. क्या फर्क पड़ता है? कोई बात नहीं. Legs folded. 5 millimeter blood pressure high. Back is not supported. 7 to 8 millimeters blood pressure high. Arm is not supported. The blood pressure would be erroneous by almost 10 millimeters of mercury. That is what is the difference. So that is why taking the right blood pressure in the right way is equally important. So if you don't have ambulatory blood pressure monitor, 3 readings at least a minute apart should be taken. And remember, only if on a single visit the blood pressure is more than 180 or a diastolic is more than 110, we are sure about hypertension. Otherwise, I never as a rule label on the first visit with a single reading that is high a hypertension. When you label a diagnosis, patient will be hypertensive for life. So that is first message that I would like to give you. What will be a normal or optimal BP? A person who is having a blood pressure of less than 130 by 85, it's good. It's relatively a normotensive person. But the moment blood pressure starts going above 130 to 139 or 85 to 89, we must consider hypertension. Now there are 2 entities. You must understand. One is that I take a blood pressure of a person, and blood pressure is high in the OPD. He's coming to you Obviously he is anxious. The chances, why you should not diagnose hypertension? भाई डॉक्टर मोहित उसकी रीडिंग तो हाई आ रही है, मैं हाइपरटेंशन क्यों नहीं डायग्नोज करूं? You may be diagnosing something that is known as a white coat hypertension. White coat means you see a white coat, a person or doctor, and his blood pressure shoots up, and truly is actually not an hypertensive. So you don't treat that person at that particular moment. And sometimes you have a person who has some problems. You know there is some problem. His history is quite suggestive of him being an hypertensive. Blood pressure is normal. Then what you may be dealing is what is called as a masked hypertension. Masked hypertension is blood patient is coming to you, BP is normal, but when you do a ambulatory blood pressure monitor, ambulatory is a instrument which is applied to the arm of the person, and 24 to 48 readings are taken throughout the day as he is doing, and you see the BP readings are high at home in the night. That is what is known as a masked hypertension. It is dangerous because the target organ damage would be happening. So three entities. Number one, a normal hypertension which you are diagnosing in the OPD, typical with the readings. Second is white coat hypertension. आप पूरे दिन ब्लड प्रेशर वो देखता है, ब्लड प्रेशर नॉर्मल आता रहता है, आपके सामने आकर ब्लड प्रेशर हाई हो जाएगा. That is white coat hypertension. And dangerous is masked hypertension, that is in the night. That is even important for the liver patient. It's relatively more high in such patients. So that is why the role of having an ambulatory blood pressure monitor is very important in this particular setup. So this is what I am saying. Look at this. Office BP is high, white coat hypertension, and home BP is also high. Then it is a sustained hypertension. That means throughout the day it is sustained. Then if office BP is low, we call it as a normotension, but if the home BP is high, this is what is known as the masked hypertension, responsible for almost 20% of the cases. So this is how an approach to hypertensive patient should be. So a person comes, ask him to sit comfortably, have a good and a simple cuff size which is fitting. Don't use a small cuff. Cuff should be absolutely appropriate. No smoking, quiet room. Use validated instruments, water validated, no mercury instruments, simple aneroid which are calibrated regularly. These are the instruments we should be using, and absolutely no talking. Legs should be uncrossed, bare arm resting, and 3 readings at 1 minute. And we have to use average of last 2 readings. 3 readings have to be taken, and we have to use average of last 2. Let me tell you, 100% compliance often is not possible in most of the government centers, but even if you use almost 50% of them, you are going to diagnose hypertension. It's the right way. So these are the 3 entities you should know. So my first message, you all should remember, 20 to 25% population undetected, or probably they are hypertensive but they are not properly diagnosed. Then we are having 3 entities: masked hypertension, BP is high at home, normal at the person's when in the clinic; white coat hypertension, BP is high with you but it is normal at home; and then there was sustained hypertension throughout the day, the blood pressure is significantly high. How would you diagnose? Have an ambulatory blood pressure monitor. Please, first thing that we should be doing as a tertiary care institute who is giving a care to most of the patients, procure and have a good, simple, economical ambulatory blood pressure monitor, 3 or 4 of them, which are going to give a lot of help and will be able to diagnose most of the patients who are not yet diagnosed. So these are the guidelines. You would say, what should be a high blood pressure? Now this is really confusing. You see, each guideline is given their own ways, but let me make it very simple for you. Very, very simple for you. For you, we must understand, look at the first column only. If the blood pressure is less than 120 and 80, we call it as a normal typically. If the blood pressure is between 120 to 129 and less than 80, it is elevated blood pressure. But this is what is concerning. Look at this. The moment blood pressure goes above 130 or a diastolic blood pressure goes above 80 to 89, this starts getting concerned, and this is what is known as stage 1 hypertension, or what often new guidelines sometimes say it is high normal. But above that, it is stage 2, and then it is seriously important to control all these blood pressure. Why this is important is because as the blood pressure progresses from a normal person to stage 1 and stage 2, the target organ damage starts happening. Kidney starts getting affected, eyes starts getting affected, heart starts getting affected, and all the parameters, you will not be getting a clearance, to operate, to do a, colonoscopy, you would not be getting a clearance to get a ERCP, because these are the patients who need to be a reasonably controlled hypertension, or at least in stage 1 or high normal, to do all these procedures. So this is important. So ideal blood pressure should be less than 130 and less than 80. Logically, what should be a good blood pressure? Anything less than 130 and anything less than 80, I'm very, very good with that. Remember, the blood pressure is a dynamic reading. So if a person says, Doctor, sometimes तो मेरा 130-80 रहता है, but दिन में कई बारी 150 और 160 पहुंच, no problem. You know, this is what is happening when we are sympathetically stimulated by various incidences. And this is where again the role of ambulatory blood pressure monitor comes. So what happens when we are using ambulatory blood pressure monitor? First, we are able to pick up all the three entities: mast, white coat and routine hypertension. Second, we are able to see the blood pressure throughout the day. What is happening? And what happens is, look at this. How would you be much wise? Typically, if we get a blood pressure reading of 140 or 150 by 90, I prescribe a telmisartan or calcium channel blocker in the morning. But when I do an ambulatory blood pressure monitor, I see, यार BP तो इसका रात को हाई जा रहा है, गोली मैं सवेरे इसको दे रहा हूँ. That is why we know what are the trends of blood pressure during the day, and this is where the role of ambulatory blood pressure comes in, and I'm able to now manage the medicines according to the need of the patient. So it's customized and designed for each patient separately. This is how we are working today. It's not that ek goli likha and kaam ho gaya. No, when the readings are high, so I will always like to get ambulatory blood pressure monitor in my serious patients and patients who need, and then I'll give a targeted therapy. So minimum medicines and you get a maximum output. Samajh mein aaya? You are clear about this? So these 5 entities you have to remember throughout their life. Now this is a case 2. This is a very simple hypertension I talked about. A case 2 comes, a marketing executive, he's a smoker, and his blood pressure is taken 30 minutes after his arrival. He has voided urine and is sitting comfortably. Blood pressure is 160 by 98. All the other parameters are normal. Fasting blood sugar and HbA1c and LDL etc. are reasonably normal. ECG is also normal. What should we do next? Now this is a person who is definitely having a high blood pressure. He has smoker but no target organ damage. No target organ damage. So look at this. In a grade 1 hypertension who is asymptomatic, no problem, with no hypertension mediated organ damage or other cardiovascular disease, we again measure the blood pressure and put him on significant lifestyle interventions, which I'll go later on. And if the blood pressure remains still high after 2 weeks, we put him on drug treatment. But look at this. The moment patient is symptomatic, he's having headache, he's having problem, this is the cases where we are concerned, with or without organ damage, we have to put them on pharmacological treatment. So home BP monitoring, ambulatory blood pressure monitoring, wherever it is feasible, should be done. And if the patient is symptomatic, along with lifestyle, remember, lifestyle modifications are mandatory. Every prescription of mine and every patient, irrespective of who they are, we strongly advocate lifestyle modifications before starting the immediate drug treatment, and then follow them up for 3 months. So what should be a office blood pressure target for this patient who is coming as a routine? It should be less than 130 by 80 millimeters of mercury. But how do we treat? The typical treatment should be lifestyle modifications. Ask him to quit smoking. That is very, very important. And medications he will require because he needs a double-digit reduction. 150 by 90 blood pressure था, 130 से कम हमें चाहिए, तो double-digit reduction चाहिए. That is why he would require double-targeted therapy, which I'll be explaining to you later. How would you evaluate a person clinically? A simple person who comes clinically, you would take a blood pressure, you will do our risk factor profile: diabetes, smoking, hypertension, dyslipidemia, and family history. These are the 5 risk factors besides the pollution, which is omnipresent in Delhi. These are the 5 risk factors which we should be aware of. And then measure the coexisting illnesses like liver disorders. You know, patients on treatment, on cancer treatment, they are the patients who are more likely and predisposed. I'll be showing on later that they are more predisposed to hypertension. And if the person is young, and hypertensive, remember to rule out secondary hypertension, which I'm going to tell you later on. Simple tests that should be done. That for each patient who's having a high blood pressure during admission or on follow-up, simple tests that have to be done. Number 1 is ECG and echo. The number 2 is very important to have a carotid ultrasound and renal artery. Renal Doppler. You might be missing just a renal artery stenosis asymptomatic in an elderly gentleman. In a young female, 12, 13, 14 year, even in a pediatric case, very commonly we find that a small child comes and he has a bilateral renal artery or a unilateral renal artery stenosis. You are giving the medicines, not getting control, patient going in a failure again and again. You check renal artery stenosis, you dilate it, and the person is normal. No problem at all. It's gone. It disappears magically. That is why renal Doppler is must in every prescription of hypertension, fundoscopy wherever it is possible. So these first 4-5 tests are important. You can click a picture. I'll share the slides with you. That echo, carotid ultrasound, renal Doppler stenosis, and fundoscopy, besides routine microscopy and hemogram, they have to be done. So these are the things that one must take care of. How do we manage the diagnose the hypertension mediated organ damage? LVH. Echo will pick up. This is not your job. You see a left ventricular hypertrophy on an ECG, that means the hypertension has started taking toll on heart. Heart muscle is getting thick. Logically, all the persons of hypertension will be contracting against a more force, and so left ventricle will hypertrophy. Then look at this. The kidney function will start going down, and these patients will typically have a EGFR which is less than 60. Let me tell you, we don't work on creatinine or urea anymore. EGFR is mandatory to guide our treatment, to prognosticate, and also to manage complicated cases. Even if you refer me a case and I have to start a drug, I have to do a EGFR to see whether these patients are having any problem or not. So in your basic case history sheet, simple module or simple calculation of a EGFR which you must be doing should be there noted, should be there. Body surface area, EGFR should be mandated in each case of a liver disease that is presenting to an organization. And then you see carotid atherosclerosis. That is why we did a carotid ultrasound, and this is important for these people. So this is how we are going to screen. Now what is the ideal blood pressure? Last, look at this, the last one. Less than 130/80, or in less than, if the person is more than 65 years, I am happy to have a blood pressure reasonably well between 140 to 90 millimeters. Don't overtreat elderly people. Let me tell you, to have an ideal blood pressure of 120 or 130, imagining or forcing towards that could be really harmful. If a blood pressure is anything between 130 to 40, patient is stable, you are good with that. Don't overtreat. That may be really, really harmful. So, and on the basis of all the diseases, if a patient is diabetic, again 130/80. Coronary artery disease, again the ideal blood pressure is 130/80. CKD, look at this again 130/80. And post stroke, we may be again having a blood pressure reasonably around 130/80. So all the comorbidities, your target blood pressure remains reasonably well. You are fine if you are saying that the blood pressure is 130/80. Then why should I start the therapy? What is the reason I should start the therapy? Remember, if we are able to manage the blood pressure normally, only 5 millimeter to 10 millimeter blood pressure reduction is going to decrease the cardiovascular events by 25%. 25% decrease in all events, stroke by 35%. That is why all the persons, all the people who are having hypertension should be normotensive before undergoing any treatment. Heart failure is going to be less, complications of the procedure is going to be less. So we must know the basic approach. And I'll share the approach that you will not need a cardiologist typically always. Legally you may ask, but logically you will never be wrong to treat the person. That is the approach that I'm going to share with you. Look at this now. Very simple and an easy graph. A high normal blood pressure, I always tell you lifestyle. Don't write medicines. 90% of my patients, I get patients from all calibers, from institutes of excellence, people who are on 4 medicines, 5 medicines, they are on medicines, 3 or 4 medicines, poor lifestyle. And let me tell you, 95% of my patients have reduced either from 4 drugs to 2 drugs, from 2 to 1 drug, and many of them are without medicines. So lifestyle modifications is mandatory. Every single day one should be doing, and I'm going to enumerate, note it down, that is always there in my prescription. Then if we have a grade 1 hypertension, again lifestyle, but if the risk is there, the left ventricular hypertrophy is there, you see EGFR is reducing, you see there is some damage that is occurring, you see the patient is significantly symptomatic, put the patient on drug. What we will tell you, simple categories, and grade 2, you put immediate treatment to all the patients drug. But look at this, lifestyle remains important in each one of them. And why? This is the reason. Look at this. Weight loss. I was 96 kgs when I came back from America, John Hopkins. I was studying there, and I was never towards my lifestyle. I had borderline hypertension, diabetes, NASH, everything in 2001, way back. And somebody told me, you want to become a cardiologist, you should look like one. That was 19th July 2001. I will never forget that day in my life. And from 19th July 2001, for 5 months, I took up to great lifestyle modifications. I changed my dietary patterns. I changed the way I used to exercise. I practiced and designed my own regimes, all evidence-based. Lost 23 kgs of weight that day. I reduced everything. My lipids have been normal. That was not the achievement. Today, 23 years down the lane, 2025, every single day I maintain the same schedule. Not a day goes in my life when I have not worked out. I typically get at 3:30 a.m., 4 a.m. in the morning after my meditation. I'll go for a very powerful workout every single day. That is the importance. That is why what I'm telling you, I'm practicing. Every day you should get up and aim a good body, good weight loss, or good controlled body weight. Healthy diet. Have a DASH diet, which is fruits, vegetables, and whole grains. These are important. Advocate these in your patients according to their needs. This is going to reduce blood pressure almost by 11 millimeters of mercury. Accessory salt. Accessory salt is in what form? Achar, papad. This is what? Achar, papad, chutneya, tinned juices, and tinned fruits. These 5 things are disastrous. Disastrous. Have a normal diet. I have never asked any of my hypertension patients to reduce salt. I ask, भैया नमक नॉर्मल खाना, लेकिन अचार, पापड़, तली हुई चीज़ें, टिन्ड जूसेस एंड टिन्ड फ्रूट्स, चटनियाँ, इनको अवॉइड करो. Preservatives इसमें होते हैं, they are disastrous. This is what where you reduce the salt. And enhanced dietary potassium in all the forms, and physical activity. If you are, noted down my statement, it's a scientific statement, if you are not exercising or moving 30 to 45 minutes every day, even if you are normal or normotensive, you are reducing 30 to 35 minutes out of your age. That's simple. This is what studies show. That is why it is important to move every day and have a focused exercise and brisk walking. And this is going to decrease your blood pressure almost by 5 to 8 millimeters of mercury. Alcohol today is not recommended in any form. Earlier it was thoda sa le lena chahiye. No, you can obviously have some time. Is strongly not recommended, because this is going to make you more hypertensive and more prone to obviously liver diseases and coronary artery diseases also. So weight loss, healthy diet, less sodium, balanced potassium, and a good activity is what constitutes a great lifestyle modifications besides breathing and meditation. Now, how do we treat these patients? What is the ideal drug treatment? Look at me now. I'm going to explain you the way nobody would have ever explained to you how do you manage hypertension. There are 3 kinds of combination. इसको समझना बड़े आराम से, बड़ा मजा आएगा आपको. 2 combination, एक first set of combination होता है which are synergistic. यानी 1 plus 1 is giving you a potency much more than 2. Second combination is additive. 1 plus 1 is equal to 2. वो अपना काम कर रहा है, वो अपना काम कर रहा है. Both are needed and they are important. And the third one is 1 plus 1 is less than 2, यानी they are cancelling or even harmful, having a harmful effect. That means there are synergistic combinations, there are additive combinations, and there are harmful combinations. Remember 4 drugs, not more than that. In your scope, remember 4 drugs. First category is AC inhibitors. सब लोग जानते हैं ना AC inhibitors. Ramipril को जानते हैं, enalapril को डालते हैं. इसको ध्यान रखिए. ये 2 drugs को ध्यान रखिए. Second category is ARBs. ARBs is angiotensin receptor blockers. There are so many. I remember only 2 drugs which are relevant to me in cardiology practice. One is telmisartan. The other one is losartan. Losartan is less because twice dosing चाहिए होती है, तो I would always prefer a telmisartan drug. So telmisartan is the second drug, ARBs. Third category is Calcium channel blockers. Calcium channel blockers, which one do you use? Typically amlodipine. और amlodipine की वजह से अगर pedal edema होता है तो clinidipine हम लोग यूज करते हैं. That is a third drug. And the fourth category is diuretics. Diuretics में दो कैटेगरी हैं, एक loop diuretics जिसको हम Lasix यानी furosemide के नाम से जानते हैं. The other one for hypertension are chlorthalidone and hydrochlorothiazide. तो ये 5 ड्रग्स अगर आपके बॉक्स के अंदर हैं, वार्ड के अंदर हैं, यू वुड नेवर 99% केसेस में देयर विल बी नो प्रॉब्लम along with the fifth category which is beta blockers, which I am going to talk about. Now look at this. What are the synergistic combinations? If a patient is uncomplicated, simple, requires a double-digit reduction, combine ACE or ARB with calcium channel blockers. This is first synergistic combination. Second, combined calcium channel blockers with hydrochlorothiazide or chlorthalidone. Second synergistic combination. Third, combined ACE or ARB with hydrochlorothiazide or chlorthalidone. That's all. Simple. Nothing more than that. You need double rate reduction. Bina पूछे calcium channel, they are safe. They are not going to do any harm to your liver patients. Very, very safe. No problem at all. Irrespective of the kind of hypertension, जब तक cardiologist आए आप एक tablet pop in करा देंगे, there is no problem. So ACE and ARBs when combined with calcium channel blockers, evidence based, they are synergistic. ACE and ARBs when combined with hydrochlorothiazide or chlorthalidone, telmisartan CT, telma CT or whatever different combinations come, उनको use करेंगे, no problem. Or if you combine calcium channel blockers with hydrochlorothiazide and chlorthalidone, no problem at all. These are synergistic combinations. Additive combinations. Additive combinations is when patient is having a sympathetic stimulation. Anxiety है patient को, young patient है, that is the patient, और patient is post MI. Special cases of hypertension है जिसमें heart attack की वजह से the LV function is also less. These are the patients where I would like to add beta blocker. I would like to add a beta blocker. This is where beta blockers के साथ वो beta blocker अपना काम करेगा. Along with it, I can add a ACE or a ARB. Along with it, I can have a calcium channel blocker and a beta blocker. No problem at all. These are the two combinations which are additive combination. So ACE ARBs with beta blocker, additive. Calcium channel blockers with beta blocker are additive. Which beta blocker should use? Noted down. ये हम सब लोग mistake करते हैं. If a person is post heart attack, note it down. If a person is post heart attack, simple metoprolol is much beneficial. Very, very beneficial. If a person is post heart attack and you need a blood pressure reduction also, bisoprolol is very beneficial. If a person is elderly, 70 plus, 75 plus, these are the persons जिसमें nebivolol is studied. Nebivolol is recommended in combination with calcium channel blockers and beta blockers. And if a person is a typically cardiomyopathic patient, metoprolol or carvedilol can be given. So these are the drugs. So typically if you want to remain safe and easy, metoprolol is a drug which is an all-season drug, not going to harm, not going to do any problem in most of your patients. So these are the combinations. So look at this. This is what it is telling you. ACE or ARB plus calcium channel blockers or diuretics. This is what I told you. More than 60 to 70% would be controlled. But if they are not acting, you need to act another third drug. The calcium channel blockers, ACE and ARB with diuretics, 90% of them will be controlled. This is the mantra. There is no rocket science in this. This is all evidence based. This is safe for all your patients also. But if those 10% are not controlled, then you are dealing with resistant hypertension. Resistant hypertension is 3 or more drugs in optimally tolerated doses. One of them is diuretic. Then the person is having resistant hypertension. This is again, look at this. The 2 drugs, then triple combination. And if it is not getting controlled, resistant hypertension. Which is the mantra or the simple, the cost-effective drug for resistant hypertension? Spironolactone. Spironolactone is one of the drugs which is very commonly used to add as an add-on therapy for treating resistant hypertension. Sometimes we have people, elderly people who come to us who are having isolated systolic hypertension. That means above blood pressure is 180, 170, and the normal blood pressure diastolic is only 70, 80. That means this is called only systolic blood pressure is very, very high. The recommended drug, which is very, very important and validated and studied, and with a trial which was published in NEGM, is which is known as natrelix or indapamide. Indapamide is a drug which is very good, magical drug for isolated systolic hypertension. Liver safe, no problem, no side effects. So these 7 drugs, if you remember: ACE, ARBs, calcium channel blockers, and diuretics, the first 4 drugs. Then if you need addition, the beta blockers, and if you need a resistant hypertension, spironolactone, and if the elderly person is there, then 7 drug is indapamide. These 7 drugs are going to complete your armamentarium for managing hypertension. Then there are special cases, as I told you: reduced ejection fraction, you add a beta blocker. You have diabetes, the management remains same. CKD, again you add a loop diuretic, you don't use any other drugs, you add a loop diuretic, which is much more beneficial in these patients. This is typically what I would be doing in these patients. Now look at this, the case 3, which is going to exemplify something different. A 65-year-old male whose hypertension for 5 years duration, 3 medicines he's already taking. His blood pressure is still 155/95. There is no postural hypertension. Fasting blood pressure is high, HbA1c is high, LDL is high, echo is concentric LVH. What is the possibility? Is this resistant hypertension, or we have to rule out something? Again, it is important for us that this is a possibility, a case of a resistant hypertension. 3 drugs, I told you which 3 drugs: calcium channel blockers, beta blockers, and then one of them is diuretic in optimal doses. Still blood pressure is high. This is possibly resistant hypertension, and we need to add spironolactone or other drugs to this. So this is a case which is perfect for adding spironolactone. If spironolactone is not affected, then we can give a prazosin or a alpha 1 blocker, or clonidine, a centrally acting agent. This comes later on. This is where the role of specialist or a cardiologist should come. But earlier, if we are able to manage on own, the first 3 drugs are more than enough. Secondary hypertension. When should you suspect? Very commonly, you will have very young people who are presenting to you, younger patients, less than 40 years, sudden worsening of hypertension. Hypertensive, first time presenting is an emergency, flash pulmonary edema, having an extensive hypertension mediated organ damage, and then having features of obstructive sleep apnea. These are 5 features where you should rule out secondary hypertension. It could be a young female, Takayasu arthritis. It could be a young child, bilateral renal artery stenosis or a fibromuscular dysplasia. It could be evenly an elderly gentleman. He may be also having a bilateral renal artery stenosis. So these are the patients. Or you may also have to rule out pheochromocytoma, which is a malignancy, and that is why adrenal screening is important. So these are the cases where you have to further investigate to rule out treatable causes of hypertension. Now look at this. If a 50-year-old male who comes with a blood pressure which shot to 180/105, he was started on amlodipine. After 4 years, it went straight to 260/150, heart failure, lethargy, drowsiness, and agar 2 months later, he had an occipital headache and he died suddenly. What is this? We have failed to avoid a hypertensive emergency. So if a patient is coming repeatedly with these episodes, remember these are patients who are prone to go into failure, and we have to know and have a good backup to maintain or manage hypertensive emergencies which we can land in. The drugs of choice for such cases are labetalol, are esmolol, IV beta blockers, not beyond your woe, but we must be aware as anesthetists and also as a cardiologist that we need these are such rare cases that may present to us in such situations. These require IV therapies, which I'm not going to go into the details. Now look at this. A 40-year-old male smoker, diabetic, presented with headache and blurred vision. Blood pressure is high. ECG showing LVH. Echo is concentric LVH. Both sugar and HbA1c is high. What is this? Look at this. Office BP 134 and home BP 168. What is the answer? People, I told you 3 entities in the beginning. मास्ड हाइपरटेंशन. सोचो ना, देखो, इफ यू जस्ट सुन के चले जाओगे मजा नहीं आएगा. यू हैव टू बी केयरफुल अबाउट दिस व्हाट यू आर डीलिंग विद. लुक एट दिस, ऑफिस बीपी 134, यू डू अ होम बीपी मॉनिटरिंग 168. यू आर सरप्राइज, यार यहाँ पे तो बीपी नॉर्मल आता है, फिर भी the ECG is showing LVH, echo is showing LVH. That means pressure is so high, it is putting an effect on the heart. That means, and when you do a ambulatory blood pressure or home BP monitoring, it's 168. This is a classical case of a masked hypertension. These are the cases where you would not be giving a blood pressure medicine in morning. You would say take a blood pressure medicine in evening. And that is how a 24-hour control, a better control will come in evening. The presence is more in younger people, more in smokers, and more with those who are not having much activity and those who are consuming alcohol. So remember, this is a very important entity, and why this is important is these patients are more prone to organ damage. That is why one must be careful about these cases. Now look at this. 85 ईयर, ध्यान से सुना, 85 ईयर, एम्बुलेटरी एक्टिव. लुक एट द ब्लड प्रेशर 170/90. रेस्ट ऑल आर नॉर्मल, LDL is normal, ECG is LVH. What is this diagnosis? A 85-year-old isolated systolic hypertension. Isolated systolic hypertension, and these are the persons where we have to increase the dose slowly, and one of the drugs of choice is indapamide. You give a single dose of indapamide 1.5 milligram, there will be a double digit reduction, and you can combine it with calcium channel blockers or ARBs. So these are the cases where you would like to have a control of 140 to 90 millimeter. I am quite happy with that. So now look at this. What would be, so for patients of liver transplantation, what is important? Hypertension often is a very frequent development after liver transplantation, and one of the key factors is immunosuppression. Unfortunately, almost 50% of the patients will develop hypertension by 6 months and almost 70% by 24 months. Management nearly remains the same. And why it is important is because it depends on the calcineurin use, steroid use, family history, obesity, age. All other risk factors are playing a significant role. And we must understand that even cyclosporin and tacrolimus both are significantly related to hypertension. Studies have shown that cyclosporin leads to more hypertension as compared to tacrolimus, but both are predisposing to hypertension. So all the patients who are undergoing liver transplantation need to be stringently monitored, frequently put at least once or twice in a year, put on ambulatory blood pressure monitor to see that what level of hypertension they are developing. Then non-alcoholic fatty liver disease, most common form of liver disease, almost 25 to 30%. You know that this studies really have shown that almost 1.72% of the patients develop hypertension much more commonly as compared to the normal population. Recently, we are conducting a study in which we are showing that patients who are presenting with STEMI. I investigated almost 5,000 patients who are presenting with acute myocardial infarction, and we have done fibroscan in 500 patients. You would be surprised that the parameters of patients who are presenting with STEMI and hypertension are far disastrous in fibroscan as compared to the normal population. So these are the patients you really have to look up to. You have to target them, you have to identify them and treat them proactively. What if nothing is working? Then today we are also having renal denervation therapy. If the patient is still having high hypertension, patient does not want to be on 3 or 4 drugs, then renal denervation therapy is a very safe and effective way to manage hypertension in cases. And what we do is we take a simple catheter in the renal artery, and circumferentially we try to ablate all the receptors, and these patients have a double digit reduction, and the requirement of blood pressure medicine goes down from 4 to almost 2 or 1. So newer therapies are also coming up. There are now injectables that are coming up, there are neprilysin inhibitors that are coming up, dual endothelin receptors. The things are evolving more and more. We are also having now newer implants that are coming up, but these are all modalities which are under investigation. Most importantly, my message is be very proactive, be very basic in managing hypertension. Sometimes we look up to big things and diagnosing and managing the big things, we miss out on small facts, simple molecules that can help us to manage hypertension. So this is the basic approach that I thought would make some sense to you. And I'm going to give you only 5 messages. Investigate everybody. 1/5 of your population, even the patients who are coming, is going to be hypertensive. So don't take it lightly, and it's going to get complicated in almost 30% of the cases. So we all, as residents, as fellows, and even as a faculty, have to take out a little effort to put that aneroid blood pressure machine. And if it is normal, fine. But if it is not, don't hesitate to take 2 or more readings. Be on a lookout for white coat and masked hypertension. If a patient is having specifically damage, get the patient on ambulatory blood pressure monitor and put a definitive diagnosis. Treatment should always be guided on the basis of this ambulatory blood pressure monitor. Third message is, have a full risk factor profile. Every person who is coming, get an ECG, get a simple echo, a screening echo, not more than 2 minutes, nothing more than 2 minutes, a simple screening echo, get a carotid ultrasound done, get a renal Doppler done. You would be missing out secondary hypertension if you don't get it done, and an ultrasound to see rule out a pheochromocytoma. And then third message is, have the good 5 drugs, 6 drugs in your armamentarium. The common drugs are ACE inhibitors, ARBs, calcium channel blockers, beta blockers, diuretics, hydrochlorothiazide, chlorthalidone, both are reasonably okay. And then diuretics, especially for the CKD patients. And for resistant hypertension, indapamide is one of the drugs should be there in our toolkit box. That is very important. Risk stratify your patients, manage them properly, counsel them, and encourage lifestyle. My 5th message is, encourage very healthy lifestyle. Practice yourself first, see the results, they are magical, and put them, strongly advocate them, and you will end up managing your patients significantly well. So thank you so much for a patient hearing. This is a brief presentation from my side. Would be happy to take up any comments or questions from your side, and we are always open to a good collaboration with you guys. It will be great to investigate, and I would strongly suggest that a simple study, you could do a very simple study in various patients who are presenting. Just use 3 readings of blood pressure, and this is what we did as a great hypertension survey. You should do a great hypertension survey in liver patients, and approximately you manage more than thousands and thousands of patients. Take a data of 5 to 10,000 patients present during the year, and I'm telling you, the results are going to be magical, and it will be publishable article. So this is the way we should do and diagnose and approach hypertension in my practice. Thank you so much. Any comment?